Great, thanks very much. Good afternoon, everyone. This is actually my first online conference during the pandemic, so I'm really delighted to be here. And I'd just like to thank the conference organisers for giving me a slot this afternoon. You'll have heard from my colleagues before me talking about the wonderful resource that is the UK HLS. And obviously it's been a really great source of data that has been repurposed for the purposes of collecting COVID-19 data. But I'm here this afternoon just to talk briefly about a new longitudinal study that has been set up over the course of the pandemic, the COVID-19 Psychological Research Consortium study. And as John said, I'm an investigator on that project. But I'm also just want to, I suppose, acknowledge the considerable contribution of my colleagues from multiple different universities. I've put up some of them here, I suppose, just to make their contribution acknowledged. But the consortium involves members from across the UK, Ulster University, where I'm based, University of Sheffield, a large proportion of my colleagues, and particularly our leader, the PI on the project, Professor Richard Bentel. But also we have collaboration across the Republic of Ireland, Maynooth University, Trinity College, Dublin, and other universities in Madrid and in Spain and in Italy. I just want to thank as well, I suppose, our universities for having faith in our idea to set up this international consortium that provided seed funding quite early on in the pandemic for the baseline and first follow-up waves, and we were successful in receiving support from the UKRI ESRC COVID-19 rapid response call in May of 2020. So there's been a large body of work that's been ongoing since I suppose March 2020. So I just really, I suppose the purpose of today, rather than maybe presenting a typical conference abstract where I'm focusing on a specific research question and presenting findings like some of my colleagues in this session, I'm generally here just to talk to you a little bit about the design of the study, how it was set up, where we're at, what the plans are, and I suppose the outputs. And obviously just to try and see where our consortium fits in, I suppose, in relation to available data for secondary research purposes in the UK and beyond. So as I said to you, it's an international consortium led by Richard Bentel at the University of Sheffield. And I suppose like many research teams, you know, I suppose none of us really anticipated what was ahead of us in March, probably a bit of a saving grace maybe, but we were quite concerned, I suppose, by the unfolding or the potential, you know, kind of ongoing nature of the pandemic, given the quite serious nature that was unfolding in relation to increasing COVID-19 infections across Europe in early March. So we wanted to, I suppose, set about establishing a large national study, primarily within the UK. So the consortium was initiated in the UK, and the parallel studies were set up quite rapidly after the UK study was established in the spring of 2020. But I suppose the aim was to conduct a large national study in the UK of the general adult population to investigate, to understand, to monitor, explain how people would respond to the existential threats posed by, at that time, the quite novel coronavirus. And we wanted to, I suppose, contribute as much as we could to the academic literature to help understand the short to medium term, I suppose, psychological, social, political, and economic impact of the pandemic, because obviously those were the key areas, I suppose, that people's lives were going to be impacted. And we wanted to, I suppose, make a small contribution if possible to help plan effectively for future public health crisis, which I think we're all maybe a little bit more aware of the potential for that now, given how long this pandemic has been going on for. So I just want to talk to you a little bit about how the study was designed. So I'm not a survey methodologist, unlike some of my peers in this session. I'm a psychologist by trade and primarily a mental health researcher, just like a lot of my colleagues in the consortium. And I suppose that's through kind of better or worse, informed our design of the study. We were particularly interested in what would the kind of psychological impact of the pandemic be, and we were primarily interested in people's experiences of what we would call common mental disorders. So, for example, generalized anxiety, major depression, and post-traumatic stress. But obviously, as experienced researchers, we were obviously very aware that mental health difficulties or experiences of psychological distress don't appear in a vacuum, and there's quite a large body of research to suggest that, you know, the social, economic and political environments in which people are living would have the potential to impact on people's mental health, I suppose, during this unprecedented time of change. So we wanted to ensure that there was quite a broad coverage of these potential protective and risk factors, because I suppose a lot of what was unfolding was not predictable really at that time. We're also mindful as well of you know, the widespread or the kind of global nature of the pandemic, and that that was kind of a unique aspect of the pandemic, how global the spread of the disease was, or the virus was at that time. But we're also kind of mindful that there were pockets of similar outbreaks of respiratory diseases in years gone by, like the H1N1 flu virus, the MERS, Middle Eastern Respiratory Syndrome, and obviously SARS, and obviously Ebola as well to a different extent. So we consulted that literature to, I suppose, be best informed as to how to design the study, or what measures and the timing, and I suppose what outcomes were particularly important to study when society was being faced by a respiratory type threat. And as I said before, the UK study was set up, or the primary or the parent strand of the consortium, and we kind of leveraged on our quite wide network of existing collaboration to set up similar studies in the Republic of Ireland, Spain and Italy. So we wanted to, I suppose, you know, my colleagues in this session have talked about mode of administration, and obviously studies that were in existence already or already established, and generally considered, you know, superior by design using probability-based sampling, were ideally suited to maybe tailor the mode of administration. But obviously we were facing setting up a new survey at that time, and we decided that an online, you know, solely online study would be the most optimal mode of administration for us, and we wanted to survey the general adult population aged 18 years and over, and we conducted, you know, obviously we were constrained a little bit by seed funding and the award, you know, that we had, but we wanted to ensure sufficiently large, I suppose, sample sizes to be able to produce robust or as robust as possible prevalence estimates for the common mental disorders, the core mental health outcomes that we were interested in. And obviously, in comparison to some of the sample sizes that have been discussed in this session, it might seem quite small in comparison, but we set the baseline sample, you know, using prior calculations based on the prevalence estimates for the least common mental disorder, which would have been post-traumatic stress. So that meant that we had a sample size of around 2,000 baseline for the UK, and that was slightly different across the other nations. It was really important to us that we included, you know, what would typically be referred to as gold standard self-report measures of common mental disorders. So I suppose this is what we would argue one of the key strengths of our consortium's work is the prioritization of these robust measures, self-report measures of common mental health problems, unlike some of the other studies maybe that are or were being established at the time that used, you know, quite short screening questionnaires, you know, 1 or 2 items for general psychological distress. We were also really mindful that, you know, mental health type surveys were mushrooming. Every week there was a new study coming out at the start of the pandemic, and we wanted to go beyond a general online survey with just self-reported data. So we prioritized at each wave the collection of, quasi-experimental data that would, I suppose, tap into potential neurocognitive mechanisms involved in risk perception relating to COVID-19 in terms of adherence to social distancing measures, etc. And as part of our ESRC funding award, we were successful in securing, modest funding for spin-off type surveys, of which the baseline sample in each of the in the UK study primarily served as a recruitment spine. So we were conducting qualitative type studies with potentially or maybe considerably vulnerable groups to the effects of the SARS-CoV-2 virus, particularly like things like frontline workers, the elderly, pregnant women, etc. So who's in the sample? I suppose, given what I've just said about the setup of the new study, we went to Qualtrics, which is probably quite well known by the audience as a kind of online marketing research panel recruitment survey company, and we adopted quota sampling methods to recruit our baseline samples in each of the country according to a number of what we felt important characteristics, age, gender, and household income in the UK, and that was slightly different in some of the other countries which recruited based on geographical and/or political region. But I suppose we've been very mindful, and one of the highlights, I suppose, of the consortium's work is that we've been committed to reporting on the methods that we've used at each wave, and we spent a lot of time demonstrating or attempting to demonstrate, I suppose, the diversity of the sample and how nationally representative it is beyond the socio-demographic characteristics that were used for quota sampling. I've one table. I appreciate it's very small here. I'm assuming these slides will be available afterwards, but we've really tried to demonstrate as far as possible that, we're particularly in the UK strand of the survey, we're demonstrating that the baseline sample that we've recruited is representative of the UK wider population in terms of country of residence, say, for example, ethnicity, economic activity, household composition, citizenship in terms of being born in the UK, etc. So unlike some of the other studies that have been set up maybe in haste after the start of the pandemic, we've been able to demonstrate that even using non-probability based sampling methods, using quota sampling, we have been able to demonstrate the representativeness of our baseline sample according to a wide range of factors that influences people's experiences during the pandemic. So how often have they been followed up? Well, I've just again put up one table, and obviously there's some of the content of this presentation. It will be available shortly as a a preprint as well. But at the moment, we've just finished our 6th wave in the UK, and we've, I suppose, unlike maybe the Understanding Society COVID survey, we've had kind of irregular intervals between some of the waves. So we had 5 waves up until the 1-year anniversary of the pandemic in March 2021. And we've just completed our 6th wave with 2 additional waves planned towards kind of the end of 2021 and around the 2-year anniversary of the initial lockdown in the UK. And in the Republic of Ireland, that funding cycle from the Health Research Board in the Republic of Ireland has just come to an end. They've successfully conducted 5 waves as well up until March of this year. Our Spanish colleagues have 3 follow-up surveys conducted with 1 additional one planned to time the 2-year follow-up. And our Italian colleagues have managed 1 additional follow-up after their baseline. And again, I suppose we are a consortium, but each of the countries has adopted slightly different approaches to the survey design. So we were fortunate, I believe, in the UK strands to be able to have the funds from the UKRI to conduct sample replenishment at certain waves of the survey in order to, in some way, replace those lost based on some of the quotas. So, we were, as I'll show you in a moment, particularly interested in filling the gaps of women and younger people, those of lower socioeconomic status that were lost to follow up. And at wave 4, towards the end of 2020, obviously we were aware that there was quite a large political event that was happening in the end of the UK withdrawal from the European Union, and we conducted quite an additional booster sample across the 4 nations to be able to collect quite important socio-political type data from a larger sample that was going to be robust enough to allow us to conduct between country analysis within the United Kingdom. So what about attrition? Well, just like a lot of my colleagues have mentioned in this session, we were conducting this survey sort of blind. Nobody really knew how long this protracted period of socio-economic upheaval was going to go on for. So it was quite uncharted territory for many research teams, including our own. And the attrition rates have varied, I suppose, across the countries. In the UK, we were successful in following up with the 1-year follow-up around 60% of our baseline sample. And as I said before, we've been closely monitoring attrition and people that were sort of dropping out. And when we go to publish a lot of our methodological reports, one of the key questions reviewers ask is, is it driven by mental health changes? From what we can see is that it generally seems to be more socio-demographic characteristics that were measured at baseline that are influencing dropout rather than people's experiences of poor mental health. And we've, again, I suppose the 2 approaches that we've taken in terms of, yes, weighting the survey to the baseline sample to account as much as possible through those types of techniques for attrition, and sampling replenishment procedures to ensure, I suppose, that our cross-sectional waves are as representative of the UK population as they can be. So what has been measured? I've briefly touched a little bit about the prioritisation of mental health outcome data at each wave. But I suppose it's around a 30-minute interview at each wave. Our participants are asked a wide variety or presented with a wide variety of measures to complete, ranging from individual level psychological factors. So we've core kind of measures on personality, cognitive reasoning, memory, happiness. We've a lot of questions about, death anxiety, COVID-related anxiety, and also things like loneliness, resilience, companionship, quality of relationships and how they've changed over the course of the pandemic. Again, quite a heavy socio-political focus. So we've focused a lot on people's attitudes towards the changing political landscape across the UK, measures of kind of trust in government, nationalism, patriotism, authoritarianism, etc. Quite a lot of data has been collected on changing economic factors, so things like changing work hours, and have people been using their savings, or have they been able to save? How has their economic status? So we've asked people about their experience of the furlough scheme, etc. And then at each wave, I suppose we've tried as far as possible to capture the context of the pandemic at that point. So at the baseline and first follow-up waves that were conducted during the first lockdown, people's knowledge of COVID-19 and how to reduce infection, and that's changed to things like experiences of COVID testing, their severity of their symptoms, their intentions about vaccination, whether or not they have been vaccinated, their experiences of self-isolation, etc. And we've also just collected geospatial type data in terms of their postcode residence, and we're hoping to be able to, that will facilitate a linkage to important administrative data for researchers that are interested in that line of research. So what has the study found? We've been busy. There's over kind of 30 peer-reviewed publications which are available on our consortium's website. Given our primary research interests, I suppose as our consortium, we focused on looking at changes in the prevalence estimates for caseness for the common mental disorders. And some of our key findings, again, I have a list at the end of the presentation, is providing evidence that, you know, the vast majority of the population of the adult population seem to have adjusted quite well, I suppose, over the course of the pandemic, given that initial spike in maybe kind of anxiety or psychological distress. There seems to have been a sort of plateauing, and we would argue that this sort of refutes the popularly held view in the media that, you know, the pandemic is causing a tsunami of mental illness, which, you know, we're challenging. We've also looked at things like the political psychological predispositions and how that relates to beliefs in COVID-19 conspiracy theories and relating to behaviours such as unwillingness to maybe get vaccinated for COVID-19 or to engage in social distancing practices. We've also, as I said, monitored people's intentions, resistance and hesitancy towards COVID-19 vaccinations and how that behaviour has changed over time. And we've worked very closely with our non-academic partner on this project, Public Health England, to feed into their COVID-19 mental health and wellbeing surveillance reports that they're published in the summer. So the main strengths, just my last slide, I've probably run over a little bit, but I suppose I've highlighted some of the key strengths, what we believe in terms of the deep content, in terms of the risk and resilience factors, the prioritization of the core mental health outcomes, relatively large samples across multiple European studies with the potential for linkage to administrative data. Non-deniable weaknesses, I suppose, are kind of the use of the non-probability sampling from opt-in market and research panels. I suppose, unlike something like Understanding Society, we don't have that comparable pre-pandemic baseline data to, I suppose, legitimately test the change of the state of play in common mental disorders across the pre and post-pandemic period. And obviously we had the exclusion of non-English speaking adults in the Republic of Ireland and the English samples. So where can I find out more? I suppose I've put up a link to our Psychological Research Consortium website, on the OSF. Our data is being released so 4 ways of the UK study are available for secondary use purposes at the moment. The Irish data is available, and we're working with our Spanish and Italian colleagues to make that available as well. We've also published, you know, quite detailed methodological reports. I've kind of led the authorship of some of those, so I'm happy for people to contact me if they have any questions about the data. But I suppose we encourage reuse of this, and particularly maybe for early career researchers or PhD type students that are interested in getting to grips with longitudinal survey data. It might be a viable option for them. Okay, thanks very much for your attention, and willing to take any questions if there are any.